something you should know the pathology, and this really helps you. And I will teach you the relevant bit as we proceed, but this is going to be the theme of the day. Okay, candidate 1, can you raise your hand, please? Candidate 1, can you hear me?
Yes, sir.
Okay, we will crack on, and we have to go quite fast. So yes. I will ask you leading questions at times, and at times on some films I will take a more traditional viva.
Right.
What do you think is this where I'm pointing out?
That's the polyp with the pedicle.
Okay, so what kind of examination has been performed?
The barium contrast study. So that's the contrast study.
Okay.
Enema.
What do you know about the malignant potential of this? Is it more risk of malignancy or less risk of malignancy? This kind of.
These kind of polyps are they are benign. However, the sessile one are malignant.
Okay, good. So, in your book, there is a differential diagnosis, the new Chapman colonic polyps on CT clonography. Of course, they have used the word CT clonography because that is in vogue. Having said that, you are not expecting images of CT clonography in the exam. On the other hand, they might show you images from barium studies, and they can show you a CT, a conventional CT. And tubular, tubulovillous, and villous polyps are there. This is from the same differential diagnosis. All of these are potential viva questions, and they have been asked. That which kind of polyp has got the highest risk of malignancy. And I've simply cut and pasted your Chapman here, villous adenoma, and they are more sessile, the variety. This one was pedunculated, tubular, so this is less likely to be malignant. And adenomas are associated with FAPs, which are extremely important. We will come back to them just in a while. Now, this is a barium enema film, and these kinds of film used to come in the exam so often in the past, maybe 15, 20 years ago. Having said that, nobody is stopping the examiners to show you similar films. Please remember, in COVID, what happened, that in many centers, barium enemas, barium meals, etc., they had a resurgence because endoscopy, CT, clonographies, etc., were not being done. So this is a double contrast barium enema film. Which position the film has been taken? This is a viva question. Candidate 1.
It's frontal.
So what is the position of the patient?
It's oblique, fronto-oblique, or lateral. Lateral.
You see, position. I'm asking you position of the patient. So you are right that this is an AP film, but the position of the patient, if you see, these are air fluid levels. Air fluid levels.
Erect.
Decubitus. The patient has to be on. Go back to the basics, and this is what happens, because I'm sure you might not have done a barium enema since years and years. That you take decubitus films, and right side down, left side down, and this is a classical exam scenario where the examiner is expecting you to tell them which film it is, and this is a decubitus film. Is there a polyp?
Yes, I can see there is a polyp on in the where there is a narrowing along with the mesenteric border. There is outpouching of the contrast.
So now, because I have not given you the mouse, can you tell me it is in this loop or this loop? Or this loop?
No, towards right side.
This side you are talking about?
Yes, down.
So this is the ileum.
Yep. So ileum, this is outpouching.
Okay.
Yes.
Okay, this good observation, but I'm not interested. Can you see a polyp in the large bowel? Hint, it is in this loop.
Okay. So is the sessile one? Yes, there is.
Mm-hmm. If you see here, look at this. Now the idea to show you this film is to develop your eyes that how do polyps look like on a double contrast barium film. If you see here, this is again a tubular polyp which has which is etched in barium, and this is how it looks like. And this, on the other hand, is an example of a sessile polyp, and we know that the risk of malignancy is more in a sessile polyp.
Yeah.
Where is the polyp in this film? I will show you another one if you raise the issue that
it's in the there. Yes, towards right side down. Yes, this is the polyp.
Okay, can you name names? So is it in the descending?
In the descending colon low part, rectosigmoid sigmoid low part. This.
Okay.
About
so
this.
It's a difficult one. This is a totally difficult. I'm not expecting anybody to pick it up here, but I'll come back to this film. The idea again is to develop your eyes. You see this, look at this. And so this is another tubular pedunculated polyp. And on this film, this is where it was. Difficult, very difficult. And but having said that, the idea is, these kinds of films was very popular in maybe 15, 20 years ago, and they can still be shown for the simple reason which I have told you. So this is another one. Okay. Now, what is happening in this bowel? What do you think is happening?
So that's again provided with the double contrast biliary enema and follow through, in which I can see there is multiple polyps are present involving the transfer as well as a descending colon. And
so this is a barium enema. You said a follow through. Maybe you meant an enema, right? So now you have picked up polyps. What are you going to advise? What is your diagnosis and what are you going to advise?
So as there are multiple, so I'm keen about the familial adenomatosis polyposis syndrome. So polyposis syndrome, I'm concerned about the familial adenomatosis polyposis syndrome. So I will further go for family screening or colonoscopy.
Right. So the point is that in there are same patient. What is this, and where is it?
So that's in the stomach. So multiple filling defects along with surrounding contrast. So that is a fundus of the stomach and multiple polyps. So I'm concerned about hematomatous polyposis or varices.
Excuse me, this is the same patient as the previous one. So how do you explain this finding?
Okay. So I can see there is a multiple filling defects are noted in the which is giving the along with the contrast uptake surrounding them. So in the stomach as well, along with the colon. So that's the polyposis syndrome again.
So what kind of polyps are you expecting in the stomach?
So they are most likely inflammatory or hematomatous.
Where else can there be polyps?
In the duodenum or small intestine. And
so how are you going to manage? What kind of polyps are you expecting in the duodenum?
In duodenum, Peutz-Jeghers syndrome, there are adenomatosis, and the polyps which are along with the colon, they are usually associated with familial adenomatosis polyposis. And
okay, let me take over. You see, the point is that FAPS is an extremely important film for your examination. And you should have an absolute clear-cut idea about various kinds of FAPS. And the most important ones are, this is page 606 in your book, as in familial adenomatosis polyposis, adenomatous polyposis, and this one Gardner syndrome, and they come in the exam again and again. And the other ones are in the list, some of which I have cut from here. Now, point to remember is that polyps can be, other than colon, polyps can be in other part of GIT. Look here, extracolonic polyps, stomach more than duodenum. Now, in all of these, they can become malignant, particularly in the duodenum. And the key thing is that we have to understand that we have to do endoscopies to keep them under control. They can be associated with other types of tumors which are here. In FAPS, all of them will develop carcinoma by the age of 40. This is a Viva question. What are you going to advise? Colonoscopy, and of course, your answer was correct. Whole of the family should be again advised colonoscopy. And second thing is that ultimately all of them will have colectomy. And in Gardner syndrome, again, very, very important for the exam. You have to understand that all of these things are associated with Gardner syndrome. Once you know this, you can see which kind of long cases can come in your exam. And if you don't know it, you might get something in, let's say, an OPG, a dentigerous cyst in ovum. And with that, there might be an osteoma in the sinus. And with that, something in the large bowel. So if you don't know this, you are not going to get the answer of your long case. Okay, this patient had previous surgery 15 years ago. And now has presented. This is a delayed film of a follow-through examination. And what is happening here? What do you think?
I think so. There is some fistula formation.
Okay, I'll show you the CT of the same patient. So actually, if you see, something is sitting here in the mesentery, and the small bowel loops are wrapped around it. So there is some soft tissue. So it becomes a story type of case. So what do you think is the story then?
So with the history of the FAP, the most common appearance of this soft tissue density lesion is suggestive of desmoid.
Okay, so this patient now, please remember, look at this, desmoid tumors. Desmoid tumors of the mesentery, of the abdominal wall, of the soft tissue. So these are extremely important. Now, so what has happened, that there is evidence of surgery. Apparently, this patient had a total colectomy, and now there is a tumor which is sitting in the mesentery, and this is displacing the small bowels around it. This patient has got, this is a 12-year-old child. I just wanted to show you the appearance of desmoid on an MR. So if you see here, this is a T2 weighted sequence, and you can see that this is low in signal intensity on T2 with its sequence. So desmoid means fibrosis, just like a fibroid of the uterus. So it is low in signal on T2 with its sequence. Okay, this is your last case, candidate 1. Can you describe it?
So that's the double contrast film in which I can see there is apple core appearance in the right ascending colon with the shouldering and narrowing of the lumen. So this shows with the background of multiple polyps in the rest of the colon. So this shows there is a development of any adenocarcinoma along with
this
yes.
On a subsequent film became absolutely normal. So this was a spasm which got clear. So I am not interested here. Can you tell me what is happening in the transverse colon, for example?
So transverse colon is a bit dilated. However, in the background of I can see there is a multiple tiny tiny filling defects are noted. So the multiple polyposis, multiple polyps are noted in the transverse colon, and the descending colon looks. So are we concerned about the descending?
Is this transverse colon normal?
No, this is not normal. There are multiple polyps, which looks like pseudopolyps. So in differential, we may include ulcerative colitis.
Okay, fine. Thank you. So you can mute yourself. Candidate 2, you should be ready. And I'm going to now tackle this film to teach you the teaching points on this film. Now, first of all, whenever you get a barium examination, may it be a solo or a, whatever it is, stomach or large bowel, small bowel, and you see some stricture or something, you have to ask the examiner that I want to confirm it on a subsequent film. You can, please remember, this is standard practice in barium films. Whenever you see a stricture, it might be because of technical reasons. The technical reasons might be that at that particular point, the loop might be collapsed. And this is something which they check in the exam. So you can tackle it in 2 ways. First of all, you can say that I want to check it in a subsequent film, or you can be more diplomatic and you can simply say that I assume that this was persistent in subsequent film. So the examiner is going to guide you, but you have to always, that's a rule in barium. Because, things like linitis plastica in stomach, you can make a fool out of yourself for the simple reason that at that point, it was underdistended. Now, what is happening is this is a film of ulcerative colitis. I'm going to show you many films of ulcerative colitis and also Crohn's disease. Now, if you go back to your pathology, please remember the difference between the two. Ulcerative colitis is a disease which just involves the large bowel. And on the other hand, Crohn's disease can involve anything in the GIT. Pathologically speaking, the main difference between the two is that ulcerative colitis is just superficial. So it will produce superficial ulcers. On the other hand, Crohn's disease is a transmural disease. So it goes through all layers of the GIT, and that's why it will cause fistulas and things like that. So the point is that if you just 1 second, why is I have muted everybody and even I can hear somebody. There is a bit of a technical issue at my end because I've muted everybody, and I can even then hear a few voices. So be careful if you can please mute yourself, all of you. Now, so transmural versus superficial, and this helps you make radiology. So deep ulcers will be seen in Crohn's disease. On the other hand, in ulcerative colitis, it will be quite superficial. There will be no fistulae in ulcerative colitis. There will be fistulae in Crohn's disease. Skip lesions is Crohn's disease. Ulcerative colitis will be continuous disease. Now, if you look carefully, what is happening? So this is one teaching point here. This was a pseudostricture. If you see the transverse colon, it has got a granular type of pattern. If you see the hostra are slightly blunted. They are not very crisp and sharp. So this granular type of pattern is because of superficial ulcers. So basically, this is a classical example of what I call develop your eyes. So if you have seen it, fine. If you have not seen it, then you won't be able to pick it up. Candidate 2, can you raise your hand, please? So, can you hear me, candidate 2?
Yeah, I can hear you.
Okay, now, how do you describe this?
Typical barium contrast enema demonstrating loss of hostra and visualize sigmoid descending transverse and visualize ascending colon on this single spot film. This almost kind of lead pipe kind of appearance of the colon. There is probably some.
So what is your conclusion?
The features are consistent with ulcerative colitis.
Okay, so why does this, how do you explain this appearance of lead pipe? What happens?
Because of, I presume because of the pre-existing superficial ulcers and the blending of hostra, I think over the long period of time, the colon kind of get a bit of fibrosed, or that's my assumption. But I probably don't know the underlying pathology.
Okay, so this is very good that you have used the word fibrosis. And please, if you open our textbook, it will always tell you that fibrosis is not a feature of ulcerative colitis. So this is what I was trying to teach you. So good that you have raised that issue. So please remember, there is no fibrosis. How do we explain this? What happens in ulcerative colitis? And this is a classical example of you know your pathology and you can make the radiology out of it. What happens that this is normal. Normal is mucosa. Under the mucosa is muscularis mucosa. Then is the submucosa. Then is the muscularis propria, and then of course the serosa. Now, what happens in ulcerative colitis? There is hypertrophy of the muscularis mucosa. If you see, this is it and how thickened it is. This is what happens. With that, in the submucosa, there is deposition of fat. And so what happens is that muscularis mucosa is a longitudinal type of, in orientation, it is a longitudinally oriented muscle. So it gets contracted, and that is why it becomes ahostra, it becomes shortened, and it gives you this kind of lead pipe appearance. And on cross-sectional imaging, as in a CT scan, if you see here, look at this rectum, and here you can see that, let me change my mouse. You can see that there is a fatty layer, and there is a submucosa, and then is the muscularis propria. So this gives you the target type of appearance, and the lumen will be narrow because the mucosa is thickened and everything is thickened. This is, again, fat in the ascending colon cecum because of the same thing. So this is the mechanism of development of the lead pipe appearance. Now, candidate 2, this is a lateral film of which area?
I can see the sacrum, so it should be either ileocecal area.
What is this?
Sorry, it's a rectum and rectosigmoid junction.
Yeah. So this is the rectum itself, right? Yeah. So the Foley's is within the rectum, and here versus this. How just try to describe this film for me.
So it's a single spot image, lateral view of the barium enema with the Foley's in place in situ. There is a kind of featureless appearance of rectum that I think that's what I can see. I cannot see any polyp or any mass or any constriction on this single spot image. That's what I can describe.
Okay, so this film, in old days, this was quite a favorite film. Now, less likely. Having said that, you have to know everything. Basically, what is happening, that this is the rectum, there is Foley's inside. This is known as the pre-sacral space. And there is widened pre-sacral space. In the difference between this film and this film is that on this film, there is an associated fistula. And here there is no fistula. So widened pre-sacral space is a differential diagnosis. In your O. Chapman, it is given that at the level of S3 to S5, if it is more than 1.5 centimeter, this is the distance between the rectum and this bone. If it is more than that, we call it widened pre-sacral space. And there is a differential diagnosis, and this is all the differential diagnosis. But in ulcerative colitis, it can happen because of a lot of inflammation or edema in the presacral space. This, on the other hand, candidate 2, if there are fistulae, then what will be, if this is an IBD, inflammatory bowel disease, out of ulcerative or Crohn's, what is
Crohn's.
Yeah, but basically, in Crohn's, you can have fistulae also. So the idea to show you these films was the concept of pre-sacral space. On a CT scan, many other things are there which can be asked in the exam, and you can read it from this 7.29. Okay, this is a spot finding, and I just want you to answer this. If you look carefully, this is a transverse colon, and you can see a unique type of an appearance here. If you see this thing, this thing, this thing, this thing.
Yeah. So it's a spot film, barium enema spot image, which is demonstrating multiple areas of filling defect, giving the kind of appearance of rose thorn ulcers.
Okay, rose thorn ulcers. You see, that is why I'm showing you this. Rose thorn ulcers are deep ulcers. And you use the word raise. I'm going to show you very shortly rose thorn. And I showed you in small bowel. Rose thorn ulcer means it is a very deep neural ulcer, giving you, if you see it in profile, it will give you a rose thorn appearance. This particular ulcer has got a very unique shape, like worm-like, filiform. And if you look carefully, then look at the hostra here, and you will appreciate that the hostra are lost. And this is a classical appearance of chronic polyps. These are actually technically pseudopolyps in IBD, and particularly seen in ulcerative colitis. And if you see, this is from your book, I've just pasted that here. Acute and chronic. Chronic, it resembles, these are known as filiform polyp, worm-like branching pattern. Why the examiners show you? Because this film tells you a story. And what is the story? Story is that this patient has got ulcerative colitis, but right now is in a quiescent stage. This is the story. And that is why it becomes a very important film. And so the idea is to develop your eyes to pick up these sessile or worm-like polyps. This, on the other hand, just to revise, if you go back, inflammatory polyp in acute stage, these are actually pseudopolyps, and these are explainable on grounds of mucosal hyperplasia. And this film you had done in your plain abdomen, so I'm not showing you plain films today. Having said that, just wanted to make that point. If you see here, this is a normal abdomen. Look at the transverse colon. Look at the crisp and sharp outline of the haustra. And here, what is happening? This is a case of toxic megacolon. And then how will you describe it in the exam is that you are going to tell the examiner that there is dilated long segment of transverse colon. With that, there is loss of haustra. There are thumbprints, so where I'm pointing out. And look here, what is projecting inside. And this is what we call pseudopolyps or acute inflammatory polyps. So this is nothing except for mucosal hyperplasia. What do you call this appearance?
These are proper thumbprints.
Thumbprints. So basic idea is, I've shown you thumbprints in small bowel also, and this is mucosal edema. There is a bit of differential diagnosis. Practically anything can cause thumbprinting, like all of these ulcerative Crohn's, etc., and even neoplasia. Okay, what do you think is happening here? How do you describe this?
Again, there is kind of filling defect, superficial filling defect in the probably transverse colon. Mm-hmm. The haustra are a bit widened and slightly blunted.
Sorry, I'm cutting you because of the time factor. So, what do you think is happening? Just describe this abnormality to me.
A couple of hyperdense spot surrounded adjacent to a bit of radiolucent area. In the background of IBD, this could represent areas of pseudopolyp.
You see, the idea is again to show you, radiological findings which you can pick up and you can describe that what it is. You have described it extremely well. That there is contrast pooling, and surrounding that is a lucency, means edema. And this is aphthyoid ulcer. You remember it, isn't it? Aphthyoid ulcer, do you remember candidate 2?
Yeah. So aphthyoid ulcer, heard about in the stomach?
No, but I told you in the stomach also that aphthyoid ulcer is a pathognomic ulcer, which is a deep ulcer. And when you see an aphthyoid ulcer, means deep transmural type of ulcer. Means if it is in colon, if it is in small bowel, if it is in stomach, esophagus, the top differential will be Crohn's disease. And so this was just to show you aphthyoid ulcers in the large bowel. Another case where you can see these aphthyoid ulcers. So please remember the difference between aphthyoid ulcers and the granular pattern which we saw in the colon in ulcerative colitis. That was superficial. So if and if the examiner tells you what can it be, then don't go into ulcerative colitis because it cannot cause arthritis. Simple as that. Okay, over to you. This is a very good film, and I want you to describe it so I'm going to give you time. Please describe it.
So it's a barium enema spot film, double contrast barium enema spot film, which is demonstrating abnormality centered in the ascending colon, a bit of transverse and descending colon as well. There are this mucosal edema in terms of thumb printing, quite marked thumb printing in the ascending colon. There's also some filling defects associated seen in the ascending and transverse proximal part of transverse colon. That is plenty flexion as well, and also in the proximal descending colon. There's also some ectoid ulcer as well, if I can see, especially in the transverse colon, distal transverse colon, and the splenic flexure. Appearances are
to the distal terminal ileum.
So distal terminal ileum is a bit narrowed as well.
So what is your conclusion?
So the appearances are quite suggestive of inflammatory bowel disease with terminal ileitis.
What do you mean inflammatory bowel disease? Choose the name.
Just on the basis of this, if I exclude my abscess ulcer finding, then terminal ileitis is more associated with the ulcerative colitis. So just on the basis of terminal ileitis and the appearance of the bowel, I think I was probably overcalling abscess ulcer if I am taking my words back. In that scenario, it should be ulcerative colitis.
Okay, I'll take over. You see, this says there are all of the features in this film are in keeping with Crohn's disease and are not in keeping with ulcerative colitis. So what are the features which are in favor of Crohn's disease? First of all, deep ulcers. And if you see, these are in profile. So this is a classical rose thorn. This is a classical rose thorn which is going. You can imagine that this must be the thickened bowel and the ulcer is going in. And when you see it in profile, it goes into the wall. Now, terminal ileitis is, terminal, don't confuse with what we call backwash ileitis in ulcerative colitis, where you can see a bit of inflammation there. On the other hand, classically, Crohn's disease involves the terminal ileum. And even in this terminal ileum, if you see where I am pointing out, and this one, these ones are rose thorn ulcers. They are deep ulcers. Even here, you can see deep ulcers. With that, you can see skip lesions. Now, skip lesions is pathognomic of Crohn's disease. This part of the large bowel is abnormal. This is normal, then abnormal, then normal. And in ulcerative colitis, by the way, within the colon, it can just involve, first of all, it can involve all of the colon, usually. It can also involve just the rectum. It can involve the left side of colon also. But there will never be these skip lesions. There will never be these deep ulcers. So this is a classical case of Crohn's disease. Okay, over to you.
Again, this is a spot film of double contrast barium enema, which is demonstrating stricture in the mid transverse colon, also in the probably hepatic flexure. There's also suggestion of some abscess ulceration in the distal transverse colon.
What's your conclusion?
So conclusion is the findings are quite in keeping with Crohn's disease.
Okay, this case is a more chronic case of Crohn's disease where you can see these fibrotic stricture here, and the idea was just to show you another stage of the same disease, and of course, is one of the one of the pathognomic findings. And please remember, as we have covered initially, lead pipe appearance is not fibrosis. That's different. And this is different. Yes, please. What's happening here?
So it's a sigmoid colon with quite marked stricture with a bit of ulceration as well, or yeah. So there's an apple core kind of structure. I cannot see the shoulder though. I cannot see the rest of the bowel. Visualize descending colon appears normal. So there's abnormality centered at the sigmoid, in the sigmoid colon, with the very thin stricture, string-like stricture. It's a short segment. So differential here could be malignant stricture, or if it's a part of the disease process, then it could represent an inflammatory bowel disease. But I'll have to see the rest of the images.
Now, this mucosa where I am pointing out, you can see the mucosa. It's going up and down, up and down, up and down. You have also said that I could not see, I think you mentioned apple core, but you could not see any mucosal destruction.
Yeah.
Now, do you agree that there is no mucosal destruction?
Yeah, there's no mucosal destruction.
So, then what is this? 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 What is this?
These are circulations of polyps kind of coming out of...
Outside the lumen. So what will it be? And you see it in each and every patient, you know.
Divertically, or diverticulitis.
Can you correlate the two then?
Yeah, so appearance are keeping with diverticulitis stricture because of diverticulitis.
Now, you are using two different terms here. Now, I'll take over. You should have a very clear-cut idea about what happens in diverticular disease. This word should be in your vocabulary: diverticular disease, then diverticular stricture, then diverticulitis, or you can say complicated, diverticulitis when you see fistulae. Those of you who are logged in from overseas, please remember that diverticular disease is one of the most common diseases in UK. And for example, in part of Asia, for example, subcontinent, etc., you don't see diverticular disease the way you see it here. And I remember when I used to do a barium enema list, I have not seen any list in which all patients might not have a few diverticuli. So there must be some genetics and there might be some dietary factors. And that is why for your exam, it's one of the most important fields, diverticular disease and the complications of it. So when there are diverticuli, there can be diverticular stricture. And again, if you read your books, it will tell you that there is hypertrophy of the muscularis propria. So where there are diverticuli, there is hypertrophy of muscularis propria. And it gives the outline of the mucosal outline a peculiar type of serrated outline. Actually, I can see the serrated outline here, but let me explain to you what happens. Look here, this is the CT scan of the same patient, and you can see, this high density thing is the mucosa, and you can see this thickened wall right and left, and you can understand let me change my mouse to a pointer form. Now you can see that how it, the mucosa goes up and down type of appearance. There is no destruction. So this is the peculiar appearance of a diverticular stricture. Now, if you see this MR, and it gives you this beautifully. So this is the lumen, and it gives you this hypertrophy of the muscularis, giving you this serrated outline. And your books tell you serrated outline. So I call it the Rambo knife sign. In my era, he was one of the favorite of Hollywood. I think 1983 or whatever, Rambo. So look at his knife. This has got this serrated outline. So similarly, serrated outline of the mucosa. Now, if you see another case which is similar to the one which I showed you, and there is a stricture here, there are diverticuli, and how it gives you this serrated outline. Now, candidate 2, can you please tell me how are you going to handle this part of the findings, and what is your diagnosis for this part?
Yeah. So there's a mucosal edema, there's serrated outline of the muscular mucosa of the sigmoid colon. There's adjacent mesenteric inflammation, and I can see an extraluminal gas locule centered in that mesenteric fat stranding. Appearances are suggestive of localized perforation of diverticular disease, in keeping with acute diverticulitis with sealed perforation. I will check the rest of the CT to look for any other extraluminal gases. The patient needs to be referred to general surgery urgently.
So what will be the management for this kind of finding?
They may choose to manage it conservatively with antibiotic if it's just a single locule, and see how if it resolves conservatively.
Okay. So okay, fine, good. Now the point is that this kind of appearance you might not find in each and every case, and in diverticular stricture, many a times in real world we are worried. We will just say that it is thickened, and we might ask for a colonoscopy, etc. The problem with colonoscopy is that many of these strictures are so tight that they might not be able to go through it. And I've got cases in my experience. We have got 4 or 5 cases in my hospital where we have been doing follow-ups just on MRs. And if you get this kind of an appearance, you are quite happy that there is no destruction going on. Having said that, coming back, please remember the main pathology which happens when we get diverticulitis. Basically, diverticulitis means that there is a perforation of a diverticuli. So initially there must be a perforation, and when the perforation occurs, there might be locule of gas. This locule of gas is sitting in the what we call the sigmoid mesentery, and there might be more than that. So don't overcall it. Don't think that this is pneumoperitoneum, because this is in the mesentery of the sigmoid. And then there can be many complications and abscesses, etc. And with abscesses, of course, in chronic diverticulitis or complicated diverticulitis, fistulae, etc. can develop, which come in the exam very often. Now, just to make my point, that this is a diverticular stricture, and this is a sigmoid colon, CA. So I'm not saying that in each and every case MR is so good or beautiful, but if you see this kind of finding, you are quite confident that there is no tumor. In the real world, it will be more gray area. Now, this is a case of complicated diverticular disease where you can see these diverticuli. There is a abscess formation here. Candidate 2, viva question. How will you manage?
We are selected axial slices of the pelvis, deep pelvis.
I have given you the finding. You just give me the management. There is abscess, and this is complicated diverticular disease. My question is, how will you manage? This is a viva question.
Needs to be referred to the surgeons, but it can be managed radiologically as well.
What are you going to offer to the surgeons?
It can be drained through CT guidance. Okay. Under the CT guidance.
I stopped you there. You had your IR session, and just to make a point is that in these kinds of films, they will ask you, and please remember the concept that if there is an abscess, usually it's interventional radiology they go for. They don't do laparotomy. They've got some criteria, clinical, but we're not going into that world. But generally speaking, most of the surgeons, they think that up to 5 centimeters, they will be more happy to go for IR help. And in your viva, once you say that, then the examiner might ask you some questions about IR, which you have already covered. This is a very, very good exam film. Over to you.
So it's a barium enema, a spot film, which is demonstrating a structure-like appearance of the sigmoid, with deep ulceration, and yeah, so there are some deep ulcers in the sigmoid. I cannot see any leakage of contrast around. I cannot see any polyps or divertically in the region. Appearances are quite suggestive of a structure.
Okay, what's happening here where I'm pointing out? What is this?
So there's the pooling of contrast through. Okay, so there's a fistulation. So it's a fistulation through the anus, or ichioanal fistulation, or anorectal fistulation. Yeah, it's perianal fistulation.
Okay, I'll take over. Now, this is an extremely good exam case, and the same case can come to you on other modalities like CT, etc. also, similar cases, even MR. Now, here what is happening is that this is the rectum, this is the sigmoid colon. Now, if you look carefully, diverticulum here, diverticulum here, diverticulum here, diverticulum here, diverticulum here. So there are multiple diverticuli. With that, from here to here, there is a stricture. But if you look carefully, look at the mucosa. These are not deep ulcers. This is that serrated outline of the mucosa which we had covered. So this is a diverticular stricture. In this case, the first thing which you are going to ask the examiner, I want to confirm it on another film. So that is a must. Once it's confirmed, then what is happening? This is the rectum. So anterior to the rectum, the contrast is going out. And you go back to the anatomy, what can be anterior to them? So this is the vagina, and this is a female. So this is a recto-vaginal fistula. So basically, it's a classical story film. The story is that this is chronic diverticulitis or complex or complicated diverticulitis with a recto-vaginal fistula. Okay, thank you, candidate 2. Candidate 3, please raise your hand. Candidate 3, can you hear me?
Yes, I can.
Okay, over to you. This patient has had surgery beforehand, as you can see. Over to you, please.
I've got a spot film from a double contrast enema, in which, and I can see there's been previous surgery as well. And the sigmoid colon appears to have a smaller caliber compared to the descending, and the rest of the bowel, the transverse and the ascending, is of normal caliber. And where I can see the sigmoid colon, it's featureless, it's narrowed. There's no fistula or diverticuli that I can see. And so I'm thinking whether this is a stricture which is secondary to post-radiation, or what the patients had for the previous malignancy, which has now been surgically managed, and the patient's having radiotherapy.
Okay, fine. I'll take over. Okay, fine, good. This is a post-radiation stricture. Now, you have to again remember your pathology, and you can make your radiology from there. Basically, post-radiation changes are because of vasculitis. You know, small vessels of of the gut, they will have inflammation. And this vasculitis will present acutely because, there can be leaky capillaries as well as there can be some hemorrhage, intramural hemorrhage, and there can be mucosal thickening, etc. But post-radiation change, unfortunately, it just goes on and on. And over the time, you can have fibrosis also. So there can be long segment strictures. You will see cases in which there can be chronic as well as acute changes. So there can be a bit of overlap. Overall, in the exam, they will always show you post-radiation where there will be some stigmata of old surgery today, like this or some other on a CT scan. Because they will show you as a story film, and you have to develop that story. And the story is that the patient had surgery. Usually, in large bowel, it is the sigmoid, the rectosigmoid, which is involved. Simple reason is that a lot of cancers in that area. In females, the gynae cancers. In males, again, similarly. So the point is that rectosigmoid is the main location for this. On the other hand, is post-radiation, where you can see long segment, more fibrotic type of stricture. But here, you can see in the transverse colon what is happening, that there is a lot of thumbprints, etc. So a bit of acute as well as chronic type of changes are there. Candidate 3, over to you. What's happening here?
So I've got a double contrast enema because I can see all large bowel here. And I can see there's this loop of bowel in which there are ovoid areas where there's no contrast in it, and multiple lucent ovoid areas within the loop of bowel. The rest of the bowel is of normal caliber. So there isn't a halo sign as such, as a target sign to suggest there's an ulcer there. And I'm thinking whether these are multiple polyps.
And it's an Aunt Minnie case. Look at the profile here. Look at the wall. This is a hint.
There's edema as well. Is this a cobblestone kind of appearance?
Right. Okay, I'll take over. So this is, actually I'd shown you similar cases in the plain abdomen one. This is nematosis coli. And nematosis coli, there is an entity in your book, nematosis intestinalis, benign, idiopathic. This is what we are talking about. Americans sometimes call this primary nematosis intestinalis. When it is in the colon, which is the most common, we call it nematosis coli. It can be in the small bowel, nematosis intestinalis cystoides. Nematosis cystoides intestinalis. Now, what is happening? First of all, remember idiopathic. So we don't know what happens. But basically, there are air bubbles sitting, neural air bubbles. These air bubbles are sitting within the wall, in this case, in the colon. And they give you this bunch of grape type of an appearance. It's an Aunt Minnie. If you see in the profile, some of these are extending outside because you are seeing them in the profile. And here they are projecting inside. And look at this plain film. On the plain film, it gives you that, again, that Aunt Minnie appearance. And look at the ones which are in the profile. Now, in our hospital, we have got a very interesting case in which I've got, CT is going back to about 10 years for this patient, who has presented with 2 times to our hospital with pneumoperitoneum without any peritonitis. So because we knew what it is, nobody acted on it. Basically, you can imagine that these air bubbles can also burst and it can cause free air, but that free air will not cause peritonitis. So you have to know this, and this is because it's an Aunt Mini case, it's an important case for the exam. Last film before I give you a 5-minute break. Yes, candidate 3, over to you.
So this is a double contrast enema which has been taken in a decubitus position, and I can see the large bowel is of normal caliber, and just looking at the ascending colon where there is some pooling.
Okay, very good. You have picked something up here.
Yeah, that, yeah.
And what do you think about this thing, this thing?
There's,
this thing?
yeah, the multiple, like when the transverse ascending and then going all the way, and I can't see any in the descending. So, and there's pooling of contrast in them, so makes me think whether these are diverticuli or polyps.
Something else, you see, look at, they're quite wide-necked. They're quite big. Okay, let me give you a hint. This patient is under the care of the rheumatologist.
So whether these are inflammatory.
Rheumatology, hint again.
So they're wide-based.
So it has to be a systemic condition, right? And
Yeah.
you are seeing a manifestation in the bowel of a systemic.
Thickened fold, or no, it doesn't look like a thickened fold.
Okay. So what comes to your mind? Oh, I've written it here. So that's a giveaway. But I'll take over. Thank you very much. And I'll give you a break after I give my explanation on this film. And after the break, it will be candidate 4. Candidate 3, thank you. Now, this is a case of scleroderma. By the way, this is a totally different case. But why I am showing you, because scleroderma is a very important exam case. And it comes in the exam again and again. You should understand various manifestations, and they will show you, because it's a multi-system, they can also show you as a long case. Now, this is what we were talking about. That film was decubitus. Here you can see these pseudo-seculations. Now, what happens? This is what we call hide-bound, just like skin, you can have hide-bound bowel in scleroderma. Basic pathology is that the muscularis propria is replaced by collagen and fibrosis. So it becomes sort of weak. So there is no muscle here. Because there is no muscle, it is replaced by collagen and fibrosis. There can be what we call pseudo-seculations. It just pops out like this and pops out like this. I have shown you this in small bowel also, where you could see pseudo-seculations at the anti-mesenteric border of the small bowel, and there was a peculiar type of finding where you can see a distended small bowel where there is crowding of folds. So I explained to you the pathology there also. So these are pseudo-seculations. In scleroderma, of course, they might show you with other stigmata of scleroderma, so you should know that. Okay, so I am now stopping here, and I'm going to mute myself. This is going to be a 5-minute break, and we'll continue after 5 minutes.